Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 262 of our pharmacotherapy series, which majors in urinary tract infections. The first question reads, TIB, a 48-year-old woman, presents with a community-acquired urinary tract infection. She has a past medical history significant only for several previous episodes of urinary tract infection. A urinalysis is ordered with the following results. Appearance, straw-colored and turbid. The normal appearance is straw-colored and clear. Specific gravity is 1.028. The normal range is 1.002 to 1.028 pH, 6.3. The normal value is 5.5 to 7.0. Glucose, ketones, and bilirubin are all negative. Normally they should all be negative. Blood and protein are both trace positive by dipstick. Normally, both should be negative. WBC, 10 to 15 cells per LPF. The normal range is 0 to 2 cells per LPF. RBC, 5 to 10 cells per LPF. The normal range is 0 to 2 cells per LPF. Bacteria are many. The normal range is 0 to rare. Epithelial cells are 3 to 5 cells per LPF. The normal is 0 to few cells per LPF. Leukocyte esterase and nitrite tests by dipstick are both positive. Normally both are negative. Of note, TIB has experienced a rash with TMPSMX and a type 1 hypersensitivity reaction to penicillins in the past. What is the role of fluoroquinolones in the treatment of TIB's community-acquired urinary tract infection? Several fluoroquinolones are indicated for the treatment of uncomplicated or complicated urinary tract infection. These include norfloxacin, ciprofloxacin, and levofloxacin. The fluoroquinolones are usually administered orally in the treatment of urinary tract infection and have excellent in vitro activity against most gram-negative organisms, including Pseudomonas aeruginosa. They are also active in vitro against many gram-positive organisms including Staphylococcus saprophyticus. The activity of many fluoroquinolones in vitro is antagonized by urine acidic pH or divalent cations. However, this is unlikely to be clinically significant because urine concentrations are several hundred-fold greater than serum levels. A large number of clinical trials have demonstrated that fluoroquinolones are very effective in the treatment of acute uncomplicated urinary tract infection with efficacy rates typically greater than 90%. Although the fluoroquinolones are as effective as TMPSMX, nitrofurantoin, or beta-lactams in treatment of uncomplicated urinary tract infection, they are no longer recommended as first-line empirical therapy because they are more expensive and provide no additional treatment benefits. Concerns also exist regarding the overuse of fluoroquinolones and the promotion of drug resistance among community-acquired uropathogens. Resistance to fluoroquinolones among organisms causing acute uncomplicated urinary tract infection is usually less than 1% to 2%. Fluoroquinolone resistance may, however, be more frequent in some geographic areas and in complicated infections. Recent studies have documented resistance to ciprofloxacin in 2% to 10% of acute uncomplicated infections, whereas it is 8% to 60% in complicated urinary tract infection. Furthermore, these quinolone-resistant strains often are resistant to multiple other antimicrobials. Concerns also exist regarding the potential for fluoroquinolones to produce collateral effects on normal flora, these alterations leading to increased risk of infection because of methicillin-resistant Staphylococcus aureus and Clostridioides difficile. Fluoroquinolones are recommended as appropriate alternatives for patients with allergies or other contraindications to the use of other first-line agents, or for patients infected with organisms resistant to multiple antibiotics, such as Pseudomonas aeruginosa. Fluoroquinolones are appropriate initial therapy in geographic areas with greater than 20% resistance of Escherichia coli to TMPSMX. However, many patients in such areas may be appropriately treated with nitrofurantoin or some other options. Finally, the fluoroquinolones are effective in treating patients with structural or functional abnormalities of the urinary tract and other complicated infections. A fluoroquinolone may be considered for TIB because she has experienced previous adverse reactions to penicillins and sulfonamides. However, nitrofurantoin or fosfomycin should be preferentially considered for TIB based on current IDSA/ESMID recommendations. If a fluoroquinolone was deemed appropriate for TIB based on other unspecified factors such as availability, cost, or tolerability issues with other treatment options, the fluoroquinolones are similar in efficacy and the choice would be based on comparative costs and compliance considerations. The duration of fluoroquinolone therapy in TIB would be 3 days. The next question reads, the decision is made to begin TIB on nitrofurantoin rather than a fluoroquinolone. After beginning nitrofurantoin monohydrate 100 mg twice daily, she complains of nausea and gastrointestinal upset after the ingestion of each dose. TIB had her nitrofurantoin prescription filled with nitrofurantoin monohydrate because it was the less expensive product at her local pharmacy. How can these gastrointestinal effects be minimized in TIB? What other important adverse effects are associated with nitrofurantoin? Nausea is a common complication of nitrofurantoin therapy, and the patient's adherence with the prescribed regimen may be affected by this side effect. It is not known whether the mechanism by which nitrofurantoin produces nausea is central or local. Taking nitrofurantoin with food may reduce nausea either through serving as a buffer or slowing the rate of absorption and reducing peak concentrations of the drug. Food, however, may also increase the bioavailability of nitrofurantoin. Slowing of absorption is particularly beneficial in decreasing the incidence of nausea and vomiting associated with the microcrystalline product. Use of the macrocrystalline preparation may also reduce adverse effects through slowing rates of dissolution and absorption, and producing lower serum levels. The disadvantage of the macrocrystalline form is the cost, which may be 2 to 10 times that of the microcrystalline form, depending on the product source. Finally, because nausea and vomiting appear to be dose-related and occur more frequently in small persons, reducing the daily dose of nitrofurantoin may also improve tolerability. However, the best studied and clinically effective dose of nitrofurantoin is 100 mg twice daily, which TIB is currently receiving. TIB should remain on her current dose. Taking the drug with food and/or switching to a macrocrystalline product should allow her to successfully finish her course of nitrofurantoin at the recommended dose. several hundred cases of nitrofurantoin-induced acute, subacute, or chronic pulmonary reactions have been reported. Acute toxicity often manifests within several days of initiating the drug with a sudden flu-like syndrome consisting of fever, dyspnea, and cough. Eosinophilia may also be present. The subacute form usually occurs after at least a month of exposure. Symptoms include fever and dyspnea. The chronic form tends to be more insidious with milder dyspnea and low-grade fever. In all forms, RALs are common and pulmonary infiltrates may be present on chest radiograph. Discontinuation of nitrofurantoin results in complete symptomatic recovery after several weeks. However, permanent fibrotic changes may persist with chronic pulmonary reactions. Re-challenge with oral nitrofurantoin results in rapid reappearance of pulmonary symptoms in those who have had an acute reaction. The drug must therefore be avoided in patients with history of nitrofurantoin-induced pulmonary toxicity. Peripheral neuropathy may also occur during nitrofurantoin therapy and is characterized by symmetric dysesthesia and paresthesia in the distal extremities, which progresses in a central and ascending fashion. Neuropathy usually occurs within the first 60 days of chronic nitrofurantoin treatment and is rarely seen during shorter courses of therapy. Symptom severity is not dose-related and is generally reversible, although more severe cases may require up to several months to resolve completely. Renal failure is a risk factor for both neurotoxicity and pulmonary toxicity, but neuropathy has also been reported in patients with normal renal function. The next question reads, patient CSS is a 2-year-old girl with a history of multiple recurrent UTIs caused by congenital urinary tract abnormalities that have not been corrected. She has had at least 9 UTIs since birth and has received multiple courses of antibiotics, including ampicillin, amoxicillin, amoxicillin clavulanate, and TMPSMX. She has also been on chronic low-dose antibiotic prophylaxis with TMPSMX. CSS was brought to her pediatrician 48 hours ago with signs and symptoms consistent with a new UTI. Suprapubertal aspiration was performed and urine samples sent for culture and sensitivity testing at that time, and CSS was empirically begun on amoxicillin clavulanate pending laboratory test results. Culture and sensitivity results, however, are now available and show more than 10^5 colonies per milliliter of Proteus mirabilis. The organism is susceptible to ciprofloxacin, gentamicin, and ertapenem and resistant to ampicillin, trimethoprim, TMPSMX, cephalexin, cefaclor, cefpodoxime, tetracycline, nitrofurantoin, and erythromycin. CSS has not clinically improved while receiving empiric amoxicillin clavulanate. What antibiotic therapy would be most appropriate for continued management of this acute infection in CSS? This case illustrates the serious dilemmas caused by antibiotic resistance among uropathogens. The pathogen isolated from CSS is resistant to all commonly used, orally administered antibiotics that have been proved effective in the treatment of urinary tract infection in pediatric patients. Penicillins, cephalosporins, nitrofurantoin, and sulfonamides are frequently recommended for treatment of pediatric urinary tract infection. However, multiple past treatment regimens and chronic antibiotic prophylaxis make these agents less suitable for treatment of this new infection in CSS. Although in vitro susceptibility testing does not accurately predict clinical response to therapy in all cases, the risk of treatment failure and poor patient outcome is significantly increased when agents to which isolates are resistant are administered. Alternative treatment is required. However, few desirable options exist for CSS. A recommended duration of antibiotic therapy in CSS would be at least 2 weeks for the treatment of this complicated and recurrent infection. Refer to subsequent sections of this chapter. Although the organism isolated from CSS is susceptible to gentamicin and this drug would be effective, parenteral, intramuscular or intravenous administration would be required, and the lengthy required treatment duration makes this far from ideal. Use of aminoglycosides would also be less desirable because of toxicity concerns. Although ertapenem would also likely be effective, there is relatively little clinical experience with this agent in the pediatric population, and ertapenem would also require parenteral administration for the duration of the treatment regimen. Fluoroquinolones are contraindicated in children and adolescents younger than 18 years of age because of concerns regarding potential musculoskeletal toxicities in juvenile populations. Although not approved for pediatric use, fluoroquinolones have been formally studied for febrile neutropenia, infectious gastroenteritis, otitis media, bacterial meningitis, and other uses in pediatric patients. The use of fluoroquinolones has substantially increased in children and adolescents, most likely owing to resistance to other antimicrobials. Approximately 520,000 prescriptions were written for patients younger than 18 years of age during 2002, of which nearly 3,000 prescriptions were for children younger than 2 years. Several reviews summarized data related to the safety of fluoroquinolones in children. Although tendinopathy or other musculoskeletal toxicities have been recorded, these toxicities have been usually mild, reversible, and occurring at rates comparable to that seen in adults. Based on currently available information and in consideration of antimicrobial resistance, the American Academy of Pediatrics has published recommendations regarding the use of fluoroquinolones in children and adolescents. These indicate that fluoroquinolones may be considered in special circumstances including a. Infections caused by multidrug-resistant pathogens for which there are no other safe and effective alternatives, and b. times when parenteral therapy is not feasible and no other effective oral agent is available. Treatment of urinary tract infection caused by multidrug-resistant, gram-negative pathogens are specifically mentioned as a potentially appropriate use for fluoroquinolones in pediatric patients. Selection of a specific agent for the treatment of urinary tract infection in CSS should be based on careful consideration of potential risks and benefits of available antibiotic options. The feasibility, risks, expenses, and inconvenience associated with prolonged, that is equal to or longer than 2 weeks, parenteral administration of an aminoglycoside or carbapenem are problematic. However, the ease of oral fluoroquinolone administration must be carefully balanced against the possible risks of using these agents in CSS. Clearly, no antibiotic of choice exists for treatment of CSS, and both the providers and the child's parents must be involved in development of an acceptable and well-informed treatment plan. The next question reads, KMM, a 55-year-old man with a history of hypertension and chronic renal failure, experiences a urinary tract infection. His creatinine clearance, determined from a recent 24-hour urine collection, is 20 ml per minute. What antimicrobial agent should be prescribed? The major problem in treating urinary tract infection in patients with renal failure is how to achieve adequate urine concentrations of the drug without causing systemic toxicity. The ideal drug would be a. inherently non-toxic, even at high serum concentrations, making dosage adjustments unnecessary. B. excreted unchanged in the urine, i.e., not metabolized, and C. eliminated by renal tubular secretion rather than glomerular filtration. Because renal tubular secretion remains active in all but the most severe cases of renal failure, antibiotics eliminated by this mechanism would reach adequate urinary levels. However, no such ideal drug exists. Nitrofurantoin and many sulfonamides are substantially metabolized by the liver and generally produce low urine levels in uremic patients. The aminoglycosides are eliminated almost exclusively by the kidneys, but uremic patients are at high risk of drug-induced toxicities and alternative agents are usually recommended. Penicillins, cephalosporins, and trimethoprim are partially metabolized by the liver but are also eliminated by the kidney to a significant extent. These agents are suitable for use in renal failure according to the criteria described above. Certain fluoroquinolones, specifically ciprofloxacin and levofloxacin, are highly excreted in the urine through a combination of filtration and tubular secretion and reach extremely high urinary concentrations. These agents are also considered safe and effective in the treatment of urinary tract infection in patients with renal failure. The next question reads, LLB, a 45-year-old woman with type 1 diabetes mellitus, comes to the emergency department complaining of severe nausea, frequent vomiting, frequent urination, fever, shaking chills, and flank pain. Positive physical findings include a temperature of 103 degrees Fahrenheit, a pulse of 110 beats per minute, blood pressure of 90 systolic 60 diastolic and costovertebral angle tenderness. A gram stain of LLB's urine reveals gram-negative rods, and a urinalysis demonstrates glucoseuria, macroscopic hematuria, 20 to 25 WBC per LPF, numerous bacteria, and WBC casts. She also has a blood sugar level of 400 mg per deciliter. LLB is admitted to the hospital with a diagnosis of acute bacterial pyelonephritis, and routine laboratory tests including a blood chemistry profile and complete blood count with differential, and specimens of urine and blood for culture and sensitivity are ordered. LLB is started on intravenous normal saline, ampicillin 1 gram IV every 6 hours, and a sliding scale schedule of regular insulin based on every 6-hour blood sugars. Which signs and symptoms in LLB are consistent with pyelonephritis? It is not always possible to differentiate clinically between upper and lower urinary tract infections. Symptoms common in lower urinary tract infection often are the only positive findings in upper urinary tract infection, i.e., subclinical pyelonephritis. LLB, however, does manifest signs and symptoms of systemic infection consistent with acute bacterial pyelonephritis, including tachycardia, hypotension, fever, nausea and vomiting, shaking chills, flank pain, costovertebral angle tenderness, hematuria, and WBC casts. In addition, her diabetes may predispose her to various renal infections, including pyelonephritis, possibly because diabetic patients have altered antibacterial defense mechanisms. The next question reads, why was LLB hospitalized? Most patients with clinical pyelonephritis have relatively mild infection and usually can be treated as outpatients. The need for hospitalization often is determined by the patient's social situation and ability to maintain an adequate fluid intake and tolerate oral medications. Patients who experience significant nausea and/or vomiting may not be able to maintain adequate hydration and thus may be at higher risk for cardiovascular complications of infection. Such patients may also require parenteral therapy initially in order to guarantee adequate initial antibiotic therapy. Finally, patients such as LLB with diabetes should be hospitalized because acute pyelonephritis may predispose her to diabetic ketoacidosis. Although blood cultures are usually obtained in patients with moderate to severe pyelonephritis, one study found that blood cultures were of low yield in the setting of acute uncomplicated pyelonephritis. They rarely provided any additional information not already obtained from the urine culture and were not helpful in the clinical management of such cases. Blood cultures may be positive in up to 25% of patients with severe or complicated pyelonephritis, however, and they are still recommended for hospitalized patients such as LLB. The next question reads, was ampicillin appropriate treatment for LLB? Ampicillin is not an appropriate choice for LLB because diabetic patients, and patients treated with corticosteroids, are susceptible to colonization with unusual or more resistant organisms. As with lower tract urinary tract infection, pyelonephritis is often classified as uncomplicated or complicated. LLB's infection would be classified as a complicated infection because of her underlying diabetes. Escherichia coli remains the predominant pathogen in complicated pyelonephritis, but other gram-negative organisms, e.g., Klebsiella, Proteus, or Pseudomonas, are found frequently. Because LLB is acutely ill and has gram-negative organisms in her urine, she should be treated with an antibiotic that has a better spectrum of activity against gram-negative organisms. Because of high rates of ampicillin resistance among common pathogens, ampicillin and amoxicillin are inappropriate for the empirical therapy of urinary tract infection, including pyelonephritis. Because LLB is to be hospitalized, broad-spectrum antibiotics appropriate for initial therapy would include parenteral third-generation cephalosporins, e.g., ceftriaxone, IV fluoroquinolones, e.g., ciprofloxacin, levofloxacin, extended-spectrum penicillins, such as piperacillin tazobactam or carbapenems. Aminoglycosides may be used empirically as either monotherapy or in combination with various beta-lactams, in combination with ampicillin to provide better activity against suspected enterococci, or together with cephalosporins or piperacillin tazobactam to provide enhanced gram-negative activity. The choice of a specific regimen is based on local susceptibility patterns and should be tailored as needed on the basis of culture and sensitivity test results. It is not always necessary to initially treat patients with anti-pseudomonal therapy, thus, agents such as ceftriaxone with relatively less activity against Pseudomonas are often appropriate as initial therapy in patients such as LLB because most hospital laboratories can report culture and sensitivity results within 48 hours. These antibiotics can be replaced with more specific ones if appropriate. The next question reads, is it necessary to achieve bactericidal concentrations of antimicrobials in the serum, or are high urinary concentrations adequate for LLB? How long should she be treated? How should therapeutic success be determined? In patients with pyelonephritis and infection of the renal parenchyma, adequate tissue concentrations of antimicrobial agents are needed. Therefore, antibiotics that achieve bactericidal concentrations in serum and kidney tissues as well as in the urine should be selected. Patients requiring hospitalization should be treated with parenteral antibiotics until fluids can be taken orally and the patient is symptomatically improved and afebrile for 24 to 48 hours. This should be followed with a course of oral antibiotics for a total duration of antimicrobial therapy of approximately 14 days. Less severe infections not requiring hospitalization are usually treated with 7 to 14-day courses, depending on the specific agent chosen. Although it is customary to observe the patient in the hospital for 24 hours after switching from parenteral to oral antibiotics before discharge, this is probably of limited benefit. Specimens for culture and sensitivity testing should be obtained on the second day of therapy, to rule out treatment failure, 2 to 3 weeks after the completion of therapy, and again at 3 months. For patients who have relapsed after 14 days, retreatment for 6 weeks usually is curative. There have been reports of successful retreatment of relapsed infection with only 5 days of treatment. However, longer courses are recommended. The next question reads, would oral therapy have been appropriate for the initial treatment of acute pyelonephritis in LLB? Patients with mild, acute pyelonephritis, no nausea, vomiting, or signs of sepsis can be treated with oral antibiotics such as fluoroquinolones for 5 to 7 days, or with TMPS-MX for 14 days. Oral fluoroquinolones are preferred agents for initial empirical therapy of acute pyelonephritis in patients not requiring hospitalization because of lower rates of resistance among common uropathogens compared to TMPS-MX, and higher rates of clinical and microbiological efficacy compared to beta-lactams. Fluoroquinolones may be particularly useful for patients potentially infected with resistant organisms because of their excellent in vitro activity against gram-negative organisms and high kidney tissue concentrations 2-fold to 10-fold greater than serum. However, fluoroquinolone resistance and risk of inappropriate initial therapy may be more common in certain geographic areas. If fluoroquinolone resistance among Escherichia coli exceeds 10%, treatment for acute pyelonephritis should be initiated with an intravenous dose of extended-spectrum cephalosporin or an aminoglycoside until culture and sensitivity test results are known. Oral agents such as amoxicillin clavulanate, cefuroxime, cefpodoxime proxetyl, or cefdinia also can be used in this setting, but the most recent guidelines suggest that oral beta-lactams are less effective than other available options and their use is somewhat discouraged as first-line treatment options. Patients such as LLB with evidence of bacteremia, e.g., fever, or shaking chills, or sepsis, e.g., hypotension, should be hospitalized and treated with parenteral antibiotics. LLB's frequent vomiting and potential inability to be successfully treated with oral antibiotics would also make initial therapy with parenteral antibiotics more favorable. Although LLB will be initially treated with parenteral antibiotics, early switch to oral therapy after as few as 1 to 4 days of treatment is recommended. Clinical outcomes with oral antibiotics are similar to those achieved with continued parenteral therapy, i.e., 5 days or longer. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 263.